Bismillahirrahmanirrahim. The topic of discussion is elbow ultrasound. First of all, we will be discussing about normal elbow, followed by pathologies in the elbow joint. And I am Dr. Sayyid Amir Gilani. First of all, we will be discussing the advantages of musculoskeletal ultrasound. It is non-invasive. It have the facility of dynamic study. Stress can be applied. It is inexpensive versus MRI. Quick examination time, bilateral comparison, patient acceptance, serial examinations can be performed to monitor changes over time, for example with or without therapy. There are few limitations of musculoskeletal ultrasound. It is very operator dependent, long learning curve, depends greatly on the experience and expertise of the operator, competition with an established modality. The indications in elbow include triceps rupture, distal biceps tendon rupture, medial and lateral epicondylitis like in golfer and tennis elbow, and ligament tears, especially ulnar collateral ligament tears. Other indications are ulnar nerve entrapment, calcification, joint effusion, and loose bodies. Let's have some words about gross anatomy. The elbow joint consists of ulnohumeral articulation, which is formed by the articulation of the ulnar trochlear notch with the humeral trochlea. Radiocapitular articulation formed by the articulation of the capitulum with the radial head, and proximal radioulnar joint, which consists of the radial head whose outer circumference articulates with the radial notch on the lateral surface of the ulna. Here we have the bones and its appearance, how it looks like anteriorly and posteriorly. This is the anterior view and the posterior view with Olecranon process and fossa. Then we have a sonogram. We can see the capitulum and the radial head forming radiocapitular articulation, and there is radiocapitular ligament. Then we have longitudinal view of the right ulnohumeral articulation, trochlea and capitulum. Proximal radioulnar joint is a separate articulation in communication with the elbow joint. Both the elbow and proximal radioulnar joints share a common fibrous capsule and synovial cavity. This joint enables pronation and supination of the hand. Here is the joint. We can see capitulum, coronoid fossa, trochlea, the medial condyle, and olecranon, ulnar trochlear notch, coronoid process is there, and this is radial notch, the radial head and radial neck. The fibrous capsule, interiorly the fibrous capsule attaches to the humerus above the radial and coronoid fossae, along the coronoid process of the ulna and to the anterior portions of the annular ligament of the radius. Posteriorly, the capsule attaches to the olecranon fossa of the humerus at the margin of the olecranon. Laterally and medially, the posterior capsule blends with the corresponding collateral ligaments. Here is the ligament at the joint. The elbow synovium. This synovial joint has the capacity of 24 to 30 ml of fluid. This synovium covers the deep surface of the fibrous capsule. Between the synovium and the capsule are the anterior and posterior fat pads. The fat pads occupying the coronoid, radial and olecranon fossae are intracapsular but extrasynovial. The synovial recesses. The distensible joint capsule may be divided into three compartments: anterior recess, radial and coronoid fossa; posterior recess, olecranon fossa; annular recess, it encircles the radial neck. Here you can see that recesses Here are the recesses of the joint synovium. Then comes longitudinal right coronoid fossa. Here is the coronoid fossa, and the longitudinal view of the right radial fossa again. This is longitudinal view of right olecranon fossa. This is the area. This is olecranon process. It is here, and here we can see these structures with recess. Transverse view of the olecranon fossa. This is olecranon process. Ligaments of the elbow include radial collateral ligaments, which are radial collateral ligament proper, lateral ulnar collateral ligament, and annular ligament. Here we can see the annular ligament, radial collateral ligament, and lateral ulnar collateral ligament. These are the radial collateral ligaments on the lateral elbow. Here is ulnar collateral ligament, longitudinal view. Here you can see that. The ulnar collateral ligaments are anterior bundle, posterior bundle, and transverse bundle. And here are that bundles, 3 type of bundles in ulnar collateral ligament. Ligaments of the elbow. The collateral ligaments are thickening of joint capsule that limit valgus and varus displacement. The sonographic appearance of tendons, parallel strands of collagen fibers, uniform thickness and echogenicity, low vascularity, may contain a tendon sheath or peritoneum. Anisotropic structures are there. Anisotropy is one of the artifacts. There is anisotropy. If a structure is at 90 degree, it is a straight, completely perpendicular to the central axis of the beam, there will be no artifact. But if partially perpendicular to the central axis of the beam, or it is a curved structure like the tendon of supraspinatus, then we can get black shadow here due to curve. That is called anisotropy. Interior structures of the elbow include biceps brachii muscle, brachialis muscle, brachial artery, and median nerve. There is longitudinal distal biceps tendon, whole of this. Medial elbow complex. The common flexors are flexor carpi radialis, palmaris longus, flexor carpi ulnaris, pronator teres, flexor digitorum superficialis. Here is the longitudinal common flexors. The muscles are here. These are the tendons. The tendons are attached here, and this is the belly of muscles. The lateral elbow complex is called the common extensors. These include extensor carpi ulnaris, extensor digiti minimi, extensor digitorum, extensor carpi radialis brevis, extensor carpi radialis longus, and brachioradialis longus. These are the common extensor tendons which are attached here. Here you can correlate it with anatomy. The posterior elbow has 2 things which are important: triceps brachii and ulnar nerve posterior and medial. There is longitudinal view of the triceps, and in the cubital fossa you can see the median nerve longitudinally and median nerve transversely at this area. Then we come to elbow ultrasound pathology. Here I am in Dubai in our seminar in April with some participants. We had 63 participants from different 13 countries, and my friend from Lugano, Switzerland, Professor Guido Rebotti. Professor Guido C. Ribotti is head of department in Regional Hospital of Lugano, Switzerland, and he is excellent in breast and interventional ultrasound and MRI. In pathologies, there are different things which we can find. The indications are triceps rupture, distal biceps tendon rupture, medial and lateral epicondylitis, ligament tears, ulnar nerve entrapment, calcifications, joint effusion and loose bodies. We can get joint effusion in all these recesses and in the joint cavity. Joint effusion can be post-traumatic, it can be infectious, inflammatory, hemorrhagic, and may contain internal echoes, but this is non-specific. Loose bodies are found in association with osteochondritis dissecans, osteochondral fracture, and synovial osteochondromatosis, associated with joint effusion due to irritated synovium. Ostophytic projections or osteochondromas may be mistaken for loose bodies. Here we have loose bodies, sagittal scan and transverse scan of the coronoid process. This is coronoid process, and here in the elbow we can see hyperacuic area giving shadows. These are multiple loose bodies. Another scan of loose bodies near to the Olecranon fossa, the posterior of the elbow joint. It is loose body. Again, loose bodies near to the this is Olecranon fossa, and here is a loose body which was here. Another case of loose bodies with a lot of fluid, inflammatory fluid there. Then we come to osteochondritis dissecans, usually occur in adolescents, may be related to acute or chronic repetitive trauma. Subchondral bone is primarily affected, and softening of subchondral bone may lead to separation of the articular cartilage. Development of loose bodies is there due to osteochondritis dissecans. Here is a case of osteochondritis dissecans, and here we can see that on X-rays, which was confirmed on ultrasound. Here it is. Then we come to triceps tendon. In triceps tendon we can get ruptures, or if there is chronic tendinitis we can get calcifications. There is a calcified area due to chronic tendinitis of the triceps tendon. Another triceps tendon in longitudinal and in transverse sections near to the Olecranon process. There is triceps tear. We scan triceps tendon at this area near to the Olecranon process, and here is chronic tendinitis. Whole of this area is involved, and some necrotic areas along with calcifications indicating chronic process. Another longitudinal scan showing calcification within the tendon of triceps indicating chronic tendinitis. Then we come to Olecranon bursitis. It is seen in Olecranon bursa. Localized tenderness will be there. Distended bursa produces a crescent contour. Olecranon bursal distension and inflammation may result from trauma, infection, rheumatoid arthritis or gout, and dry tap aspiration is possible.